drug manufacturer, or a device maker, you're in great shape. And as I said earlier, I am not an engineer or a scientist by training. It would have been interesting to team up with a company that's creating therapeutics and cures or cool devices or improving procedures and having something that really changes, outcomes for patients and all these things that I would truly love to do. But there's a lot of that. There's a lot of PhDs out there that are a lot brighter than I am on the tech side. And while they are still hungry for good MBA business thinkers and doers, it's just a subset of entrepreneurship. And of course, if you can sell to major providers, that's great too. If you have something that improves, healthcare delivery or care navigation or actual treatments or even, processes within care environments. But as you probably know, if you've had conversations about healthcare entrepreneurship, this is also a really tough world to sell anything into. Giant companies, super slow sales cycles, and some of them directly, told me each one of them is an aircraft carrier of a company. They don't want a solution until it's already at scale and proven to work at scale for some other kind of entity. And it is really tough. The conversations I've had with people in this category are kind of like, maybe we could do a little trial, over in this corner. And if it really proves itself out, maybe in 2 or 3 years and prove it in some other, smaller hospital, maybe we'll get to adopting it. And then there is a pitfall, which is not the topic of this chat. It's really, you could spend another entire chat about working with big provider organizations, but there is a trap that often, especially software-based digital projects get built. You start working and you're super excited because you're working with a major top 10 largest in the country. That one, if you're working with a healthcare provider organization, there's such a big potential customer. People end up building their product to suit the needs of the particular system they're working with. And it's not a pitfall that everybody succumbs to, but it is something that can be very distracting and can take entrepreneurs down the wrong roads. So all that to say, there's nothing, I too would like to be the hip 28-year-old entrepreneur with a hockey stick growth pattern for a product for any of these kinds of companies. I am well past that life stage. If you have it, go for it. It can be great, but it's definitely only a tiny part of things. In the back of my mind, if I could do anything, is to help set all of us up for the idea that there's a different stage to think about entrepreneurship at. It's great that you're thinking about it now. I wish I thought about it more when I was in graduate school. But there's also this stage about 10 or 12 years into a career. You really have relationships and knowledge, and you know people, and you know how these companies really work. And at that stage, you have credibility and experience. That's also a great time to think about entrepreneurship. It's asking you to look ahead, but it's worth thinking about even now. Think about it now, because when you're 10 to 12 years in, statistically, life changes. People have spouses and partners. Some of them have kids. You have homes and there's stability, and you're on a track of earning money that you've been waiting to earn because you've invested all this time in school and graduate school. It's tough to walk away from something 10 or 12 years in. But those are the kind of people, I wish I was running into those people now to team up with, because they just have relationships and knowledge that's really good. And it's tough though. I've been there in another industry, and what it is to be 10 or 12 years in. It's not easy to just turn around and step aside. But anyway, all that said, I want to take a couple minutes and just walk through a few underlying characteristics of the U.S. healthcare system that, again, you're probably familiar with them, but it's framework for the real entrepreneurial examples and things that I want to talk about later. And it's kind of fun. So let's imagine that we're sort of, we're going to remind ourselves briefly about what the U.S. healthcare system is designed and not designed to do. So if your health is approaching, some sort of hairpin turn, we want to remember that our system is not one that puts up warning signs or barriers. It's not incentivized particularly to prevent sickness, injury, or financial harm. It's incentivized for other things, generally. There's exceptions here and there. Our system, more or less, waits for someone with a healthcare condition to have this sort of thing happen. Their healthcare condition goes off a cliff, they need immediate, serious, and acute care, and we tend to build hospitals expensively, ready to treat them after they have this kind of problem. Hospitals, as you may know, take in about 37% of the average healthcare dollar, the largest single category of our national healthcare spending. And so, as we all know, It's really more of I'd say a sick care system than a healthcare system. I put this up here because I want to remind us collectively that words matter. And the words that I've seen around healthcare are not particularly conducive to helping people think entrepreneurially. Words subconsciously impact our thinking, and many of them mislead. So here's a few that we can take a look at. Reimbursement's an interesting word. It's commonly used to refer to payments that occur to entities that sell products and services in the healthcare system. But no one would normally think to use that word. The idea that a hospital, if you think about what reimbursement's really about, simply paying someone back for something that they spent out of pocket. Kids can understand the concept. But when hospitals talk about being reimbursed, it's almost a subtle subconscious way of implying that we're a hospital. We expended some money on your care and we just want to be reimbursed what we put out. We just want to break even on our care. This subtle messaging is just bizarre to me. And nowhere else do I see words like this used in any other industry. And there's several of these kind of things. They just dampen innovative thinking. Here's another one we hear all the time, the high cost of healthcare. So I'll just take us back to Econ 101, just as a quick reminder. Cost is probably more properly thought of as the money that an entity expends to build something, to manufacture something, to deliver a service. And it's very distinct from what happens when you present it to a customer and ask for money. That's the price you ask for. And we conflate those two things all the time. And we make it difficult. So I would prefer always that we think about the high prices of healthcare. And this type of thinking, I think, will lead us to interesting entrepreneurial places. A couple more. One more is funny to me always. Payers. I get it. Payers are generally, these people. They pay out the money, but it distracts our mind from what they are, of course, really doing. They are more properly processing payments. They handle claims. They adjudicate claims. They do, approvals of treatments and whatnot, and then they simply process claims and pay out money that they take in from people who pay their premiums. You might say, hey, Jim, but of course, don't they do some underwriting in some cases and take a little bit of risk? Yeah, if you're buying certain kinds of fully insured health plans, these companies do take risk briefly. I don't think there are ever net payers very long. If they take risk and it turns out that some insured person had big expenses and they briefly lose money on paying those out, we all know what they do. They adjust the premiums, and in the second or third year after that, they make it up. So they never are net payers very long. Their fundamental goal is processing. They take your money, they process it into claims, and that's really what we oddly call them payers. It distracts us from the fact that payers are individuals paying through high deductibles or buying individual plans. Payers are employers, who in 2 seconds we're going to talk about whose money that really is. And payers are us as taxpayers. I could have included Medicare and Medicaid in there too. They belong as payers. But it's a giant misnomer, and I'll try to avoid the word. But like everyone else, I'm sucked into the lingo that we're given. Last one here, just to show that the mindset of growing up in America is not that conducive to disruptive entrepreneurship anyway. We do have this thing called the employer contribution. Those of you who had jobs or might get jobs at any company, I think larger than 50 employees, employers have to offer employer health care. And we all use the phrase, my employer gives me health care, or the employer makes a contribution for my health care. And the mental image is the employer is like giving us money or giving us a benefit. And we shouldn't forget for a minute that compensation is always the full package of what employees get from employers. If employers, for some reason, didn't have to, or employees didn't want that compensation as healthcare, in theory, employers could take that money and hand it to employees as cash. It is earned compensation, every bit of it. And employees are using their money to pay for their healthcare through their employer. And for those of you that studied a little bit of tax policy on healthcare, you might know that it is simply a unique and not to be underestimated tax issue, tax quirk, too small of a word, but a tax issue in the U.S. that when employees receive healthcare benefits from their employer through an employer plan, they're not taxed on that benefit as personal income. And that has a lot to do with why we have some of the structure that we have in healthcare today. But like so many times as we talk today, I'm going to leave that aside. That's policy, public policy of healthcare. We're on the road to where are the entrepreneurship opportunities. So the real place that got me thinking about this was walking myself through the supply chain for healthcare when it comes to employers. And as I mentioned earlier, although this is not all of American healthcare, Medicare and Medicaid are absolutely giant. Some people aren't insured, but I'd say about half our population gets healthcare through their employers. And let's just go around the imaginary proverbial table just so we can see what separates the person or the entity that arranges for your healthcare and all the way around until it's actually delivered to you if you happen to be a patient that day. So the first thing we take a look at here is the employer. I said actual purchaser, I really mean the person who conducts the purchase. We know a few minutes ago that the money they use really belongs to the underlying employees. But it is the employers who pick out the plans, decide what employees are going to get to choose from, and they're the ones that maybe after COBRA terminate their plans if you leave their employment. If you're the employee, you're sitting all the way at the other end of the conference table and you're wondering what goes on between me and the source decision, the decision about what kind of plan do I have and what kind of healthcare is coming my way. So let's look at the cash flow. That employer starts out talking to probably a broker, maybe more higher level, we'll call them a benefits consultant, who whether or not that employer is self-insuring or buying a fully insured plan, that consultant is there to talk to them about what kind of plans they want to offer, how it will be structured, whose network will be accessed to provide them healthcare. And a lot of those brokers and benefits consultants turn to general agencies actually to get multiple quotes on health plans. Those agencies are also paid fees that come from the premiums that are paid through the employer, but ultimately by the employee. And then finally, you've got this insurance company that's put into place. Either they're selling their network or their full underwriting insurance services to insure the employees of the employer. And as we walk through this is the cash flow as well. Money gets taken out at the broker level or paid to the brokerage and then handed over to the insurance company. So maybe, let's just say 10% is taken at the broker level and the rest gets put into the hands of an insurance company who, as we know, pays it out to health systems and to pharmacy benefit managers. In a moment, we can draw a few other dotted lines. Sure, insurance companies often own pharmacy benefit managers and that money flows through them. But money gets out into the health system in those two major categories. Yeah.
What's the difference between a general agency and an insurance company?
A general agency is a firm that provides services to benefits consultants and brokers. A lot of benefits consultants that would turn to a company and say, let me bring you quotes for Aetna, Humana, and United. They turn to many of them, if they're small, they turn to a general agency, a firm that provides various kinds of support services to health insurance brokers, including fast and easy multiple quotes so that someone can say, look, I've got an employer, they've got 80 employees, and here's the basic census info about the employees. Go get me quotes from 5 or 6 big insurers.
They're almost like a distributor. Or
yeah, they're kind of like an extra wholesale level distributor. Yeah. And they often, whether it's, you can think of it as whether they split commissions with whether the general agency splits commissions with the broker. If the broker is really big, there may not be a general agency involved. They may have that folded in if you're dealing with, USI or some, Willis Towers Watson companies that's a big established broker. So they're not always present. But it gets more fun here. Here's the rest of the players about what happens, though. We know that there's physicians and practice groups. And then other big players, there's device manufacturers that sell their products into health systems. There's actual pharma that develop drugs and distribute them through pharmacy benefit management programs. And these are all the people. This is my view of the value chain of what it takes to get from the employer before services are actually rendered to an employee. It's not perfectly linear. Obviously, sometimes it's a physician, sometimes it's a hospital. The employee might be refilling subscriptions at a pharmacy that has a deal with a pharmacy benefit manager. But these are the players. And it's a very curious group. Because if you ask yourself this question, does any of them not benefit when prices go up? And it's my thesis today that every one of them benefits when prices increase in the healthcare system. And this is pretty fundamental. What kind of a marketplace do we have when every significant participant benefits when prices go up? Certainly the payer here and the person there, the employee paying a deductible, they're not too happy about it. But brokers, a commission on the money that's spent, as well as a general agency. Insurance companies we'll talk more about in a few minutes, but by and large, let's go with me on this, that the more money that flows through their hands, the more money they make. We can come back to them in a bit. Health systems, sure. The more money, the more things that are purchased from them, the higher pricing they can place on things, the better off they are. The higher prices that device manufacturers and pharma can put on their products and obtain, the better off they are. Same performance of benefit managers. And doctors, generally very happy if their prices can go up. They tend to perform practice groups when prices rise. So where has this left our entire system a little bit in recent years? Because I think the opportunities for entrepreneurship are getting better and more acute as this kind of time goes on. Yeah, this is okay. Insurance companies own these, and sometimes there's a few dotted line relationships. I just got a little too crazy. Let's look at something. Here's an analysis of Texas Hospital's really neat organization that has cost information about every hospital in the country on their website. Just the basic concept, and this is indicative of what happened throughout the U.S. That we have cost basis, and there are some cost reports that hospitals are required to provide the federal government. It's one of the only insights into the underlying cost structure of hospitals. And I'll lay odds that most hospitals do not have a good handle on what their costs are. They are billion-dollar businesses, some of them, and they can't tell you what it costs very clearly to render a certain service. Go to any other business that's well-run in the country, and they can tell you the cost of the paper clip sitting on the desk or the cost of the tires that they're putting on their automobile. Just amazing. So, the hospital charges have gone up significantly in recent years and disproportionately to costs. When you separate this out, especially into two segments of the market, and you look at, Medicare, their prices, not that different. They move up and down, and, CMS adjusts their prices. But the private sector has taken an amazing leap. I know this is not terribly recent. This was just the best one that I had, and NASHP's a really good organization. I'll update the slide someday, but let's go with it. But this has been, even if it's leveled off a bit, there's a giant divergence that private organizations, and when I say private, I mean not Medicare and not Medicaid. There is little reason to have much distinction between nonprofit hospitals and for-profit hospitals. They're still serving private patients, private like employer commercial insured patients. So this problem leaves us with a really tricky spot. You might say, well, hey, what about insurance companies? Isn't it their job to try to minimize their claims payments? And therefore they operate as one choke point in this system of everybody being happy with prices going up. Isn't it their job to say, hey, let's push back on that? Well, not really. Holistically, the more money that flows through the insurance company, the more money they make. Legally, ever since the ACA, all this leaves us with a terribly shaky foundation, but I want to get to this slide. All of this, here's where I wanted to go. These players, the relationship between insurance companies and health systems and physicians. The insurance companies, by law, pursuant to the ACA, are not able to get very far reducing claims payments and then capturing the remaining money as their profit. The ACA has a medical loss ratio cap, which went into effect whatever year in 2008 that the ACA went into effect. And it says to insurers that you can only retain about 15% relative to your claims payments. And so if they reduce claims payments, the 15% that they're able to retain gets that much smaller. And the bottom line is, if they want to grow the amount of the portion they can keep for admin and profit and everything else is in here. And if they can grow the total amount of claims expenditures by higher utilization or higher prices, or simply growing the number of insureds that they have, the part of the pie that they do get to keep, that 15% grows. So they don't actually have a financial incentive. They might have a moral incentive. They might have a political incentive. They might have community, commitments to try to look like they are, and maybe make some efforts to reducing prices and controlling them. But by and large, their fundamental underlying economic incentive is to grow the amount of total claims payments that they make. So with that, I'll say that even insurance companies are not functioning in a way that limits prices. Yes.
Does that mean like the same procedure now costed a lot less like 10 years ago and they're just charging more for the same procedure, or?
Yes. Healthcare prices for the same procedure have grown beyond faster than the rate of inflation for many years. And so there would be lots of questions. Scarcity of medical personnel and supply and demand maybe would argue for that. But globally, as you may have heard, the US spends, and it's not that our prices are about double what other comparable industrialized democracies are. And there's much study and issues around why. But there are other countries that prove that you don't need to pay at the level we pay. You don't need to price things at the level we price. But they are priced there for various reasons. So let's just see what would have happened if, good thing, great segue though. What if something else that we're familiar with had increased at the same rate healthcare prices have increased over the last 40 or 50 years? So over the long haul, if food prices had gone up as much as healthcare prices, we would be paying $57 for a dozen oranges, $65 for a dozen eggs, and $160 for a gallon of milk. No one in the United States would stand for this, but we stand for it in healthcare because few people embrace it, follow it, track it, understand it. For good policy reasons, I'm not saying that it's a bad thing to have people disconnected from the price of their care. But when the economics underlying an industry don't have players that are disconnected from it, we have the problems in part that we have today. Can't pin everything on pricing, but pricing is certainly a big deal. And it can be done. I mean, you would think let's even take academic institutions. I can go to the student store and find reasonable and fair prices on food and items and water like this. I can go buy food on campus, and sometimes they run these things maybe at a rough break even. I don't know what UCLA does these days, but they're not there to make total maximum profits. They're there to serve students. But they absolutely do not adopt that thinking at UCLA Health or any other major academic medical center. They have different issues, pressures, objectives, and goals. And the way ASUCLA provides coffee down there for $3 for a latte or whatever, or $5 or whatever it is, depending what's happening. And I don't want to pin it on UCLA. I would say this to anyway. This happens at every major nonprofit academic medical institution. So what else we got? For 2 seconds, just to think about this, what is the general social contract with healthcare enterprises? Well, first off, all healthcare benefits, as I mentioned, when they're received by employees, they're not subject to income tax for the employees. That, by the way, is the largest federal tax expenditure. The U.S. forgoes more income tax for perhaps a very good policy purpose. Not here to talk about policy, just here to say how much money do we put into subsidizing healthcare, and we still have shockingly high prices. So it's a very big tax expenditure. And then hospitals also, when they are in the non-for-profit category, they are relieved of paying state, federal, and local taxes. And when you start to see, and again, I don't want to blame UCLA; they're the same as any other. But as an example, purely as an example, I think we're recording this too. When you drive around town and you see UCLA Health on small office buildings or small places that used to be private practices, when a healthcare system buys, a small private practice, and if that practice owned their own, building, then a nonprofit is buying them. It takes that building off the local tax rolls and increases the tax pressure on the remaining residents and businesses. Not-for-profit status is a big boon to the institutions that are not-for-profit, but not enough work is done in really analyzing how much are we foregoing in community and state and federal taxes. And there's one other place too where we give healthcare a big help. When big systems go for public bond funding, many of them, state by state differently, are eligible for tax-exempt bond funding. So by the way, if you want to really have some fun, and you're a finance student, you're really thinking about hospital finances, you look at the news that are reports about hospitals, which is what hospitals typically say. Things like, we are losing money. We had a terrible time in the pandemic, and millions of dollars of losses are reported, usually on a consolidated basis. And then You look at their SEC filings for bond filings, and they paint a picture of a stable, more profitable institution that's able to pay repay the bonds on schedule. Very interesting difference between what the PR departments are doing in hospitals and what some window into their actual finances are. And by the way, of course, when hospitals report on a consolidated basis, everything that's an expense goes into the final calculation of whether they lost money last year. Hospitals pay some of their C-suite executives and CEOs phenomenally high salaries, and hospitals that have, grand pianos and waterfalls in the lobby, all of that was money they spent on building their infrastructure. And if they're losing money, that's because expenses were higher than revenue. So a lot of reporting about hospital finances is something worth taking a deeper look at. We're getting to the entrepreneurial stuff. So, okay, let's see where this goes. Where does some of this impact entrepreneurship? Quick overview of last thing though here. So we're in a world where competition in US healthcare is scarce. What we don't do, we fail to create conditions that foster competition. We fail to enforce with antitrust law where to ensure that there's competition. And where we don't have competition, we don't do much regulation of dominant healthcare systems in certain regions where competition is impossible. So in this whole environment that we've been talking about, US healthcare as an industry constitutes the largest sector of the largest economy that the world has ever seen. Is the largest business sector in the United States. Two key things I think characterize it for our purposes. There's a long-standing dysfunctional equilibrium present in the healthcare system, and it does provide essential services. It's worthy of all kinds of public policy and business entrepreneurship thinking, and most of it is irresponsibly priced. I chose the word irresponsibly intentionally. I do think that there is a moral issue about how we charge and price health services. We have huge amounts of programs going to the effort of how we can fund and allow people to afford them. But one of the best things we could do to increase access, equity, and availability of healthcare is to think about whether it is priced appropriately. And there's a lot of good evidence that says it is. So I'm not here to dive into the evidence. I'm here to talk about how businesses can be built that operate successfully because of these bizarro characteristics of the healthcare system. So one of the most interesting ones to talk about is the notion of social determinants of health, those things that are outside of the clinical world that have been shown to impact whether people are high utilizers of our expensive health system. Financing them is notoriously difficult. These are things like, if people have transportation and food and good education and community support services, they tend to not wind up in hospitals so often. And I have come across a couple of interesting reports and trials in this area that I think are ripe for entrepreneurial opportunities. So they involve the multi-stakeholder collaboration issue when it comes to projects like this. And there is a really good article. Afterwards, I can come back to this page if any of you want the link. But it has been studied interestingly, and some trials have been started to look at whether you could bring multiple parties together with interesting financial structures to enable programs to be invested in and pursued that the marketplace wouldn't normally support. So just as a quick example of what they did as a test, and someone wrote this up, so I'm just really reporting on some interesting research that I've seen, they went around and they found look, let's find different stakeholders. And they were looking at, a community of people who were high utilizers of the healthcare system. They went to, I think it was some hospitals. Hospitals don't make a lot of money on Medicaid patients. And some of them actually will contribute money to a program that would help keep Medicaid patients healthy and not need their hospital services, so that the hospital has beds available for people who are insured that pay higher prices. Morally, it's kind of bizarre. And we're going to leave aside again the issues about whether we should have a system that has some patients who pay well and are preferred by hospitals and others who don't. The fact is we have it. And they were able to say, look, let's find how much money different hospitals would contribute to a program that might have been education or food, healthy food, or transportation in a community. They also went to a local criminal justice system. And I think they had some research that said, if you have better education, healthier food available, transportation available, and maybe daycare available, that in communities that support these types of things, you tend to have less teenagers that wind up in the criminal justice system. And they had some statistics that showed on their program, here's what they expected to achieve. And here's the key part. No single party had either the cash or when they looked at the amount of patient benefit that they would get, none of them added up to enough that any individual party would support the whole program. But collectively, when they each assessed how much would they bid basically for a certain kind of program, they got multiple parties, and sometimes, it could be, people that are institutions that are already involved in social services like, juvenile justice system and as well as hospitals. They each bid a certain price, and then the people promoting the project said, great, you'll each deliver this much money to us. And they put a performance guarantee. They said, we will achieve certain X objectives, and only if we achieve those objectives within our 2-year program, then you'll pay us the money. And then they went to a private philanthropy and said, hey, why don't you loan us the money? And in 2 years, if we achieve success, we will actually pay you back the money because our constituent stakeholders will each pay on their contract when we achieve their social good. And of course, if they fail, then the philanthropy loses its money. But guess what? The philanthropy was already in the business of giving money to programs that get spent and do some degree of success or failure, often very hard to measure. So anyhow, if that's an area that strikes you, I thought it was a pretty fascinating thing to think about how one could scale and sustainably finance programs that address social determinants of health issues that don't really have a marketplace functional marketplace for those things. The big picture is public-private partnerships of this sort are probably something that we could really benefit from having a marketplace in come the next global public health crisis. And one organization that's doing this in a small way is here in LA. There's a guy, Dr. Michael Hockman, who was involved with medical students. They were doing street medicine for unhoused people in various parts of LA. And they had simply one benefactor. They went to some of the hospitals and said, how many unhoused people wind up in your emergency room and then in your hospital for which they collect very little reimbursement in the long run? And hospitals said, yes, this happens to us and it's a big financial problem for our hospital. And he said, and I don't know the details of the contract, but he essentially said, look, why don't you pay us X amount of dollars, and with our street team, we will work with unhoused individuals on the street, and we believe we can keep them healthier and therefore not showing up in the emergency room and not being a financial drain on the hospital. I think the hospital was essentially saying they don't get any money for treating unhoused people, and this was appealing to the hospital. That with a little public money from LA County, and he had a business that was launched. Whether it's scalable nationwide, I don't know, but he's doing it. And if you're really interested in that, chase me down sometime and I'll get some of that for you. Let's move on though. Some of the real meat and potatoes of how to deal with entrepreneurial opportunities that can address some of the high prices in healthcare. Risk management is a fascinating area of opportunity for this. It is a data-driven area that is not fully utilizing all data that's available to make good risk management decisions. And if you can measure risk more accurately and better than the traditional methods that the Aetna, United, Humana, and Cigna giant insurers are doing, you could arguably find a place where you are able to be more competitive than they are. And there are companies that are adopting health plans that don't, because they're expensive on a lot of levels, including the overhead built into those companies. There is a marketplace for companies that want to find health insurance for their employees that does not go to those big, expensive national brands. You don't run into them when you hang out in Silicon Valley and LA and media and entertainment. California and a lot of the coastal states, we have a lot of companies that are simply wealthy enough to just, hold their nose, sign the contract, and pay for expensive health insurance through those big national health insurers. But if you go out to the Midwest, we have blue-collar, smaller companies, blue-collar manufacturing, companies where every dollar really matters. A lot of them are looking for ways to cut their healthcare expenditure. For many companies, the highest budget line item is employee salaries, and the second highest budget line item is healthcare for their employees. There is a famous quote, I don't know if it's true, that Starbucks spends more money on employee healthcare than they spend on coffee beans. Something like that. If it's not actually true, it's probably close. So what goes on in risk measurement? Yeah, there's some interesting entrepreneurship I've seen in underwriting efficiency and provision. They're using non-traditional sources. They're adjusting for the impact of other people who are doing innovative care delivery models. So all those other entrepreneurs that are thinking about ways to, to manage people's care better from a clinical sense, well, shouldn't those more efficient systems be reflected in a lower insurance cost? And there are people working on that, including that in their underwriting data. So here's a couple examples if you're really into it. This impacts the prices for claims processing and management, utilization management. All of these component areas of in health insurers are impacted on the when you can improve the nature of risk measurement and management. So who's doing this? Here's two interesting companies that are out there looking at data. That, again, some people it's controversial in some senses. We all know that with a little bit of money, you can buy access to social media data, purchasing history data, all kinds of stuff that we all don't like because it's scooped up from us every time we use the internet. But there it is. It's for sale. Companies are using it in all manner of shape and things. And they are improving upon estimating healthcare risk based on many factors that come from collecting data that is breadcrumbs on the internet, instead of just doing a traditional way, which would be, let's look at whether you're male or female, where you live, the zip code, and maybe a couple of other data points, and then assessing some, healthcare premium and underwriting based on that. So that's a far improvement, I think, from what these companies are doing. I'm sure, I don't know what goes on deep inside the bowels of each of these giants. They're probably working on that too. But these are two recent entrants to the market that are, using all kinds of non-standard, non-traditional data sources. Yeah.
So I was just going to mention what you just mentioned a moment ago. Like this sounds to me more anti-consumer, right? Like I should not be charged. Well, I would like not to be charged more if somebody knows that I purchase X food that's not good for me, right? Go somewhere that's harmful to my health. Right?
What about the flip side? What if whatever you're doing that's identifiable on the internet means that you should be charged less? Now, you might still say, my data is private. I don't want you to charge me more or less based on my personal purchasing habits. Right. But I'm here to say that this tiny group I'm part of called Excel Health Plans is looking to provide employers lower priced healthcare, because part of one of several elements of our package is that we're reducing the cost of the underwriting risk, because we are able to identify data sources that allow us to argue to the underwriter that the prices should actually be lower.
Yeah, because I remember there was a similar use case with automotive where AAA wanted to get access to iPhone accelerometers in a car.
Right, and see how you're driving.
Yeah, see how jerky you're driving, how fast you're driving, to better assess your quality of driving. And I don't think it took off for whatever reason, but it sounds similar.
Yeah, and it depends on the baseline. If they assume everybody drives, like the proverbial grandmother, then those few that are driving like a race car will be revealed and they'll be charged more. But if they assume everyone drives like it's a race car and you and I drive more responsibly, we might be entitled to a reduction. So I tend to think that what we're finding, and we're not deep into this, I don't have a gazillion data points, but we have paying customers for health plans that are being better priced, in part because I think that the big health insurers sort of assume the worst. They're in the business of charging high premiums and not taking a ton of risk. So I think they should assume the worst. And if you can uncover an employer that has 40 employees, those employees on average are a little bit healthier based on some internet data points that are available, I think we're using it to charge less.
The thesis is more so that people are actually healthier, qualitatively healthier than they think, and therefore their premium should actually be less than what they're being charged.
Yeah, I'm not ready to say that that's really a strong hypothesis, but I would like to believe that people may be healthier than these groups think. The fact is, it's group by group in the employer market. You're looking at one employer group, they might have 40, 50, 80, 200 people. And each group is just too unrepresentative of a larger sample to say people are healthier. There's a lot of smart people in here too. I don't want to say people are healthier than they say. But where they are healthier, we'd like to find them and reward them with a more competitive offering than these have. But this element of price is only one factor in the entirety of what, a healthcare premium dollar is for an employer. But it's part of it, and it's a place where some neat underwriting is going on. So what else is out there? We're running out of time, and we're just getting to the good stuff. Care delivery, certainly there's some neat stuff happening here. Even though I said I wasn't highly focused on clinical stuff, there are business models that are innovative and worth talking about. So I've seen one company focusing on condition-specific products and services. Thrive Health is an example. But the fact that they looked at a large patient population and said, we don't need to be inside the hospital dealing with how care is delivered to these people. Certain populations like diabetics often need supplies, delivered to their home. Much like Dollar Shave Club, they're out there delivering, the equipment for, at-home blood testing and blood sugar monitoring and various supplies that people need on an outgoing basis. They're delivering them cheaper than the standard healthcare system suppliers. And they're out there innovating in doing simple, efficient, and lower cost delivery of something that people used to pay more for. So they're super serving a customer segment at a lower price point than the traditional system is doing. There's another company I didn't put up here that, for instance, is also, doing durable medical equipment, crutches, and those big plastic boots that go on your feet if you sprain your ankle. We all know that if you buy those at the doctor's office, they're $500. If you buy them on Amazon, they're $50. But they're packaging it up, they're working with health plans and employers, and they're making it easy to have it delivered on your doorstep just as fast as Amazon would. And so it's a customer service innovation and a product price point in a narrow category that they're doing well with. What else? There's business models that actually impact the clinical relationships. Resilient is one example of many, but they're doing something really neat in the direct primary care space. The idea that employers might take a Netflix model to primary care. One of the reasons that I will contend that, and there's research to back this up, that so many people wind up in expensive hospitals is that they forego primary care. They have a big deductible, they don't see their doctor often enough. So this is the Netflix model. Pay one monthly fee for every one of your employees, and your employees can go to our primary care practice all they want, every day, whatever they need. And it's super encouraging of patients to do a very necessary thing. And they're coupling that with what I'd call innovative and enhanced telehealth. Telehealth, you might just think of as a Zoom call between you and your doctor. They're rapidly building clinics. They're very lightweight clinics. They can be put in any building, in any city, and they hire a paramedic to meet you there at the office. And the paramedic does the hands-on stuff while the doctor is, is available on screen. But literally, if they're looking in your ear or doing something, the doctor can say, move the camera a little bit here. I want to take a closer look at that. Position the, skin lesion or something in a better space. You get real hands-on patient stuff and blood draws and other things done with a lower cost but effective paramedic level person while the physician is at a remote distance. And that's turning out to be a very efficient care model for them, and they can deliver a pretty good monthly rate. We're talking like no more than a cell phone bill per month for an employer for their employees to have access to primary care that operates in a really different model like this. Much better than many people are saying. They feel that that's better than the traditional primary care models. Another company that's doing something interesting, because we're going to run out of time too much. A virtual network by tapping into excess supply. So Blue Cross has a network of providers. United Healthcare has a network of providers. It's expensive to go around and have contracts with all these providers and specialists and hospitals and clinics. But this one company said, you know what? We're just going to have a network for imaging only. And where is the most expensive imaging? It's probably at big academic medical centers or big for-profit hospitals. And of course, there is a system there that if you're seeing a primary care physician that's connected to a big system, they are expected and often required to refer patients to the imaging center that's within the large hospital health system that they work for. In many cases, it's part of the doctor's contract. But many people are sent out or choose to go out for imaging that is less expensive. And that was kind of an innovation 20 years ago. You can see imaging centers and MRI centers that are set up in different places independently. What green imaging did was they realized that a lot of those independent imaging centers, they do have people that often work, 14, their staff, let's say 12 hours a day, but only for 9 or 10 hours of those days are they booked. And Green Imaging, whose name you will never see on any building, has gone around all of these, or many, in top 30, 40 cities in the country. They've gone around to imaging centers and said, if we could send you extra patients that arguably you wouldn't be getting otherwise, will you give us a price break? And especially you can try to schedule them in when you have downtime or unutilized supply. And so they turn to people, Green Imaging does, to employers and other health plans and says, you know what, if you want to save money on imaging, have us coordinate your imaging. And in almost every major city in the US, they can find a third-party imaging center that normally charges a high price, and they will have access to them for a steeply discounted price because they're soaking up excess capacity. I don't know what other areas. Obviously, you can't do this quite as easily in every other area of healthcare, but maybe labs. A lot of people charge a lot of money for labs. Lab is just a blood draw, and then that blood goes off to a lab somewhere. Most labs are, like less than $50 to perform, but a lot of practices charge far more than $50 for a lab. So they are finding markets and customers for this approach to thinking about where is their excess supply, how can we soak it up and package it and redeliver it. And so they're a neat little thing. What else do we have? We have, and by the way, like I mentioned on Resilient, they use paramedics. I read somewhere that former military medics are the fourth most unemployed category among Army veterans. What a neat opportunity to find excess skills that might be employable at a good price to fold into certain systems. And probably that's what Resilient is thinking. Maybe I'll suggest that to them. Real big, I'm going to skip this for a moment. This is just, you see that I'm thinking a lot about where is there waste in the U.S. healthcare system that's related to entrepreneurial opportunities. The waste is huge, by the way. The entire economy of Brazil is about $1.5 trillion, and that is the estimates, not of the U.S. healthcare economy, but the waste in the U.S. healthcare economy is about equivalent to Brazil's entire GDP. Some have estimated it at about $1.5 trillion. Now, there's ineffective care, unnecessary care, there's outright fraud. A lot of things that we'll talk about in the remaining 5 minutes are not necessarily addressable through easy entrepreneurship, but there's a lot out there that can be. So a lot of your colleagues might be excited about financial and fintech opportunities, and think about all the money you could save if you could build a payment system that would displace credit cards. Probably some of your friends have talked about that. The typical take on for a credit card company is probably 2 to 3%. And we know that people are in the market innovating with payment systems that might only take 1% or less out of every transaction. And if you could have a company that would foster adoption of that, you'd all be gazillionaires. So that's really impressive, the amount of money that could be made and how much effort is going into entrepreneurial thinking to take a market that takes, call it 2.5% in your Visa or MasterCard, and have a system that shaves it down to maybe 1% or less. Yeah, that's a good opportunity. No problem for anyone going for that. There was a study by a guy named David Schenker at Stanford, and his estimate, when you look at the transaction costs in healthcare, on both sides combined, between the payers and the providers, the equivalent type of transaction cost is about 20%. 19 to 26%, whatever he came out with. An outrageous and massive amount of transaction costs. Sure, it might be a little more complicated to administer the fact that a hospital, has a billion prices for a billion things, but being able to put together billing and payment systems that can bring down the cost of the absurd transaction costs that exist in healthcare is a great entrepreneurial challenge, and I think it's highly worthy of everybody to be thinking about. Let me speed up and go on to a couple more things before we wrap up. Innovative contracting. Aside from billing and payments, the contracting process is slow and expensive. And there is a model out there for an industry that did it right. The swaps industry. Don't know if any of you have backgrounds in finance, but the international currency swaps used to have contracts that on average cost $100,000 with legal fees to negotiate. They adopted, and this would be the ISDA, which is like the International Swaps International Swaps Dealers Association. They created a standardized system for contracts. They had a certain set number of parameters that affect the key financial variables for a swaps contract. they got the average contracting price down to $5,000. Could we do something like that with the laborious, ridiculously expensive sets of contracts that happen between hospitals and employers, probably hospitals and insurance companies? We should and we could. And if you stick around afterwards, I'll show you an example of how many contracts and pricing permutations a typical hospital has. It's ridiculously high. What else we got? Because we're running out. So payment claims and payments. What else can I tell you about this? That there are companies that are independently doing plan administration outside of those big insurance companies. A lot of innovation there. Price transparency is something that is growing. That's a space that I'm in with Firelight. Verification and auditing. Most entities that pay a hospital, if it's through a health plan, don't have a reliable, good way of answering the question: did we bill the correct amount, and did we pay the correct, or did we get paid the right amount? Backtracking and auditing and verifying that payments were accurate. There are a number of hospitals, I've talked to a few of them, who simply say, we submit the bill to the insurance company, money comes in, and we don't check or audit, we just assume it's right, and we go forward. It's too much trouble, we can't figure it out, and we don't know. So that's ridiculous. No business sends an invoice without knowing what's the right amount and being able to double check that they got paid the right amount for the right things. But it happens. So billing systems practices, really big. I'm going to skip a little bit of this, but the underlying system of this is really absurdly complex with how the codes are set up in hospitals and how bills are issued. The fact that the cataloging and coding system that hospitals use is actually owned as a copyrighted property by the American Medical Association. Everyone who uses that system for billing and payments pays them a royalty. They make about $230 million a year. It is out of a total of $385 million in revenue. It is by far the American Medical Association's biggest source of revenue, charging people a royalty to use a complicated set of numbers that identify about 10,000 different procedures. It's ridiculous that that money should be paid to use a set of numbers. Certainly we could have a simpler and better contracting system. Bottom line is, people want to know things like, I'm buying a car. I have parameters. It may have an air conditioning or not, or it may have, fancy tires or rims or not. We have basic ideas of what we want to buy, but healthcare sells not the car. They sell things like this. They provide bills with countless detail of individual codes, attach prices to each one of them that no one can understand, and it's a system ripe for innovation and disruption. It's just positioning a company in the right spot to do it is tricky, but it's really worth it. So, there are some other programs out there I'm going to skip because we're running out of time. This is what some typical hospital pricing looks like. This is the easy one to uncover and to analyze. It's truly an area where there is incredible inefficiency and waste. No one would design a system like the system we have. I'll skip this little bit of detail. I want you to know that it's not just the pricing. The pricing results in a dysfunctional market. The Wall Street Journal reported not long ago, they looked at a few different hospital procedures. Price variability is outrageous, a factor of 10. There is no efficient market that I know of where an item at one provider is 10 times the cost of the item at another provider. Any efficient market, we might have 10, 20, 30% variability. You're buying extra quantity. You're willing to drive across town. You get a better deal. You don't pay 10 times what another equally quality provider provides. But it can happen in healthcare, especially in hospitals. All this produces terrible societal effects. We have incredible amounts of medical debt. You know that. I think briefly we'll just recap and wrap it up, though, that there are multi-stakeholder collaborations. There's risk measurement, risk management opportunities. There's these condition-specific products and services where you can super serve certain market segments. Business models that change clinical efficiency, like the Amazon model for primary care, and then certain super narrow networks that provide lower cost services in certain categories, lower cost contracting, claims and payments. All of these are they're crying out for business process improvements and business process innovation. No PhD, no science and engineering really needed other than some tech skills. Disrupting practices and systems. So I'll conclude by saying, the US healthcare system is really this giant ball game where everybody involved bumps up against these bumpers and cash registers go off every single time. If we can find opportunities for entrepreneurship that can bring efficiency and just functionality to this market, we can try to bring the game over to the entire ridiculous edifice that is built up to extract cash and put it into the healthcare system. So that's my thoughts. Thank you very much for hanging out. Sorry I used the whole time. Really, thank you. A pleasure being able to present all this. And I'm around for a few minutes for any questions. And we can do it formally while the recording is going on, but that'll probably end soon. But I don't know if I can get questions from those who are watching by Zoom. But if you have any, yeah.
So I know you focus a lot on the hospital space. What are your thoughts on the biotech and pharmaceutical industry?
I think they're terrific. I think they're always looking for a new therapy that they can sell into the healthcare marketplace. And mostly the entrepreneurship I see in that area is centered around those who are teamed up with, drug development programs. And or tech transfer, where they're taking technology from universities that would form the basis for new drugs. I think it's great if you find an entrepreneurial opportunity to develop new therapies and sell them to the biopharma space, and that's a perfectly valid, good route. I didn't talk about it a lot because they talk about it all the time. There are examples, and they get well publicized. Yeah, get a successful new drug, go to town, help the world, make a ton of money. What's better than that? It's the get a successful new drug. Massive capital investment to develop and get through the FDA, serious multiple rounds of financing, and a lot of them don't want to just finance one drug, they want a portfolio approach. It's a big money and a big game. And if you've got a PhD and you're developing a big drug, I'm all for it. It's not the area that I found to be overlooked, shall we say. Yeah.
How do you anticipate the value-based payment structure as opposed to fee for service? How do you expect that to sort of impact what you're seeing in the opportunities?
I expect it to not derail the things I talked about. It's actually one of the slides I burned through really quickly. It's a good point. There are accountable care organizations. There are bundled payments. There are shared savings models. The academic research that I have read about these seems to say that they are not producing a lot of net savings. I think what happens is most health systems say, oh yeah, they do two things. Oh yeah, we want to participate in, value-based care and shared savings. We want to make sure we're not getting any less than we have been getting paid, but if we can produce some savings, we'll share in some of it. And fundamentally, they're not in the business of seeing their revenue get reduced or take risks on reducing their revenue. So at best, it might be flattening the curve a little bit, but the more academic research supports the view that I subscribe to, it's not making that much difference. And the vast majority of American healthcare is still delivered on a fee-for-service basis. And for all the good, and I do believe that many physicians and clinicians of all types, they don't want to prescribe and overdo. But as far as financial incentives go, that is their financial incentive to deliver more care and have it built for under a fee-for-service system. And then there is this quote that I don't know where to dig up the quote, but enough people have repeated it that I tend to believe it. There was a hospital executive that also said, we're going to ride this fee-for-service horse until it drops dead. And there's a reason a hospital executive might say that. Yeah.
Good. Thank you again for this presentation. I enjoyed it. One of the most frustrating things as a consumer in healthcare is not knowing on the front end what I need to pay for something. I from my own experience, I had a post treatment thing where I met with the doctor for like 5 minutes over Zoom. I get a bill 2 weeks later that it was $40. I didn't know that. If I were to know that, I wouldn't have taken that meeting. So how do companies or businesses solve?
Thank you. We could have used you a month ago. I work with a nonprofit that is very passionate about promoting price disclosures and price transparency. They were being interviewed, I think, by a New York Times journalist, and it had to do with the fact that hospitals are starting to say that they're getting, wasn't just telehealth, but it was all the emailed correspondence between physicians and their patients. And some hospital systems want to start billing for email messages, or essentially, text messages through their system. If the question was, how do we know this so that people don't, make decisions they would rather not make? There are a few organizations. One of them is called Turquoise Health. Another is, Turquoise is probably the most prominent one out there. And they are providing a free portal online where you could go look up your hospital and hopefully identify the price for the service you would be getting, and you would be able to know in advance. And it is broken down by health plans, so you can say how much money